Now, coming to mesh fixation techniques, that's very important. How do you fix the mesh? Number one, either tacks, only sutures, or tack plus sutures, right? Either tack, sutures, or tack plus sutures. As far as tacks are concerned, we all know shorter operating time. We have the gun, cut, and end. Very happy. That sound is very, very pleasing to the ear. It's as if you are shooting a gun. And you try to apply as much as you want in your workshop, then you apply even more. In a workshop, you try to apply twice what you have done in your private practice. You always do that. Right. Everybody does it. Not only us, everybody does it. I've seen all operators in the workshop, national workshop, and they always put twice the amount they would have put in their private practice. Anyway, so it has a shorter operating time, less post-operative pain, acute or chronic pain. We're talking post-operative pain, whether it's acute or chronic, and better cost process. Probably maybe right to a certain extent, but not totally. The absorbable tax and non-absorbable tax, again, this comes into play. Increased recurrences with absorbable tax, that may not be always true. But what is always true is that the absorbable tax are costlier than an absorbable tax. Because suppose if you use an absorbable tax along with the transfacial suture or some kind of suture, then the absorbable tax will serve its purpose. The recurrence will not be there. But if you're just using absorbable tax only, then yes, the recurrence will be there, right? So, but then, of course, the non-absorbable tax are costlier. That's why you cannot pick over the non-absorbable tax. They're still considered to be better than absorbable tax, right? But the problem comes that they are probably beneficial when you have to stick to bony structures or ligaments where applying sutures is very difficult. So, yeah, they have their own usage. And the method of application should either be double crown or is better than single crown. So, either one layer of circular or double layer of circular sutures. Right? If you're applying sutures, you've got two types of sutures. One, transfacial, that is running through the abdominal wall, fixing the mesh to the abdominal wall. This mesh wall, you fix it, and then you bury the knot subcutaneously. Right? That's a transfacial suture for you. Right? Now, okay. So the second method of suturing is basically a suturing where you've got a intracorporeal suturing. So cost-effective and stronger attachment to the abdominal wall, but increased chronic pain with TFS. That means transfacial sutures. Agreed. Why? It's running through the abdominal wall, being tightened. So part of the abdominal wall is the grip of the suture. Pain has to be there. So when you have a transfacial suture, mesh fixation, it should always be lateral to the rectus abdominis. Always remember that. Why? It is less traumatic and it's a stronger grip. In the rectus abdominis, through passing two layers of sheath, it becomes more traumatic, right? But if you're using an intracorporeal suturing, along with TFS is probably much better. Why? Because just apply 2 or say 4 at the corner, the rest of it you stitch to the peritoneum. So that is basically good, but it is time consuming, right? And the technical challenge is always there. One other advantages that, remember when we talked about recurrence, so we'll talk about recurrences, the recurrences always occur at the interface or the margins of the mesh. But if you're applying an intracorporeal suture, the margin of the mesh is always sutured by the intracorporeal suture. So from the margin, you would not have any recurrence, right? So best is tack plus suture. Maximum fixation with reduced operating time, and that is advisable. So the general impression transfacial sutures are more painful, may not be holding too much water, and there are a number of prospective comparative trials available. So as of today, apply suturing with tacks. Whether you want to intracorporeal or you want transfacial suturing. I think we talked about this when we were talking about the ventral hernias, but just so I repeat it out here, apart from the tacks and sutures, you can also use laser assisted tissue welding. You can use a fiber and sealant, or you can use a glue. Right? So these are the other methods. Apart from tacks and sutures, you can use glues, you can use laser. This is just a figure out here. And I'd like to tell you about the absorbable because these are now coming into the market. This is basically Medtronic or the Covidial, Sorbafix. These are the absorbable tacks out here. This is the one of the most commonly used absorbable, and this is the Ethicon absorbable secure strap. Then you got the Profound A and the absorber tack. This is basically absorber tack. So basically, just remember that there are absorbable tacks available. I don't know sutures. Sorry if I'm saying suture, I'm wrong. Absorbable tacks now available, but till now, the most common 90% are still using the ProTack. The Covidian ProTack is basically the most commonly tack being used. I think 90% of the time people are using 90% of the time the people are still using the ProTack. right? And this is the double crown. You can see in two layers, layer 1 and layer 2. And this is basically what do you mean now? This is layer 1 and this is layer 2. Just a example. Now coming to the last part, there's a complication of meshes. I'll just run through this. It won't take too much time. If you look at the complication, infections to the tune of almost 10%, recurrence 12% or more, depending upon whether it's open or it is a laparoscopic mesh repair. Adhesions 36% to almost 100%. Don't confuse these adhesions with adhesive intestinal obstruction. Not to be confused. When we say adhesions, we say that the viscera is stuck to it. Doesn't mean it's undergone obstruction. The obstruction, the obstruction would be somewhere in the area of 12%, but adhesions almost would be 36 to 100%, depending upon what kind of mesh has been inserted. Erosion and fistulization 0.7 to 7%, or more than 7%. I'll tell you when it is 7%. Chronic pain and other complications like migration, rolling, displacement by seroma or hematoma, extrusion of the mesh through a defect, and fistulization into a bladder. Infection, synthetic or other meshes, I think we have dedicated one single lecture to it. I'll just be running through it with just 2 or 3 slides. There's no difference between mesh and no mesh. The true incident wound infection is difficult to determine, but just stick to 9%. That is the most important figure. People do say 3%. I think with post-operative surveillance should be somewhere in the region of 9%. And it increases the post-operative morbidity so much. It's highly morbid. Mesh infection is highly morbid. And the word is highly morbid. Why? Because it creates a problem both for the patient and the surgeon. The presence of prosthesis, it lowers the number of organisms required to create infection from 10.6 to 10.3 to 10 to the power 3. That means half the organisms are required now to create an infection as compared to a scenario where there was no mesh. Right? Now, what happens when the process is there? We told you it applies it gets a protein coagulum, right? So that is a glycoproteinaceous binding for the excellar matrix. It's now wet, right? Now it's wet for what? It's wet for attachment either to normal cells or wet for attachment to the bacteria. First come, first serve basis. Bacteria came first, yes, come and attach. Cell came first, now you come and attach. So it's first come, first serve basis. Whichever comes would be attaching to the processes which has got a layering of the extracellular matrix, right? And now there would be cross linkage either with the cell or with the bacteria. And how does the bacteria attach itself? The bacteria basically attach. Why? Because when the bacteria enters, it also gets a extracellular matrix coating. It also gets that extra polysaccharide polymer is there. So that also gets some matrix. This has got a surrounding excellar matrix surrounding, and this also got the same thing. But in addition to this, what else the bacteria has done is it has also got surface components recognizing adhesive matrix molecules. So it is going to stick to what? It's going to stick to the matrix which is covering the process. Forming what? This is what is known as a biofilm. So when next time you come across the term biofilm, just remember biofilm is basically the film which is formed by a particular bacteria with the extracellular matrix and the adhesive molecules. Together combined, they may be attaching to the cell. See, it's attaching to the dead cell. It can also be attaching to a live cell or to the process either. So this is basically an attachment. And this biofilm the bacteria creates. Why? It wants to remain for a longer period of time. It improves the bacterial survival. It does not allow these the antibiotics to reach that particular area. They're killed by the biofilm. They don't reach that particular area. Less phagocytes reach that particular area. The antibody response is also decreased. And the biofilm also produces beta-lactamases. So increases resistance to antibiotics. So this biofilm is the troublemaker. The bacteria has created a biofilm and the troublemaker creating all these problems which ultimately translate into what? Persistence of infection. Right? So when you talk about the pathophysiology, you have to have a hydrophobic would be better. Why? Because it's going to repel the water in the bacteria. A hydrophilic probably would be having a wicking effect which would help the bacteria enter into the mesh filament. So when you talk about infection, these two, the PP and the PET meshes are more susceptible to infection as compared to PTFE. Right? And also the PTFE has got another problem, and that is the problem on the other side is that the PTFE requires lesser organisms to invade it before it can transmit infection. So PTFE is repelling the organism, But even half the organisms, so 100 times less organisms, what PP has got would be infecting a PTF. And the other problem is, because the PTF has got very small pores, the phagocytes don't reach it. The fighting cells don't reach it. So once infection goes into the mesh spaces of a PTFE, it's not going to be treated early, right? The planar placer mesh is again a very important part, and that is if you have a IPOM or if you got one of the layers inside, you've got different kind of infection rates. So peritoneum only 1.4, but this basically if you got a open, you got almost 45%, with closed 12% when you got an inlay mesh appear. The causative organisms, we all know Staphylococcus aureus, MRSA are very common. Streptococcus beta pyogenes, gram-negative, Candida, and atypical and typical mycobacteria. They are the common organisms. So that's basically why vancomycin and linezolid are the two common antibiotics with which you should start the treatment. So once you recognize infection, you have to be careful whether it's a superficial infection or a deep infection. We all talked about that earlier. So if it's a superficial parietal inflammation, it is you're fortunate, the patient is fortunate, can be treated just by treating a SSI, which is superficial. But if there's mesh infection, you wouldn't be knowing about it in the early stages. Why? Because the meshes being has a pus layer inside. So the outer layers don't show you that layer, that pus or inflammation. It's only the passive time. So it will be manifesting late. And that late manifestation can be anywhere from 4 months to 4 years or immediate within a week. So within a week, the underlying pus can manifest superficially, or from 4 months to 4 years, which would be a delayed presentation of a mesh infection, right? So initially no local signs, but later on, those who present 4 months to 4 years, even then they don't have a local sign. I've told you about the base presentation. I'm not going to go into that detail again. We already touched on that in the earlier lectures. So just how do you manage that? If it is superficial infection, nothing has to be done. Just minor drainage of the pus and conservative antibiotic. But if it is a mesh infection, then either you drain the cavity, irrigate it, or more often than not, you have to explant the mesh either partially or totally. So bottom line, you have to explant the mesh, but just so that you remember this, 25% of the time, probably now they say you can save the mesh. Anyway, preventing infection is more important. So how do you do it? Let the infection not occur. Hemostasis, minimal cauterization, minimal tension, necrosis propagates dead tissue. No drain in the particular hernia. I have seen a number of papers where they put in a drain after doing a TEP or TAPP. Why? Because they wanted to decrease themselves seroma formation. Never do it. As far as I'm concerned, as far as the logic and scientific knowledge concerned, don't do it. Antibiotic prophylaxis, a dogmatic no. Why? Because you're doing a clean wound. But prudently, yes, do it. Use antibiotic. When you have an old patient, you have a suspect patient, other comorbidities, you expect the infection to occur, you're not very sure about the sterilization, use antibiotic. So prudently, always use antibiotic prophylaxis. Dogmatically, you can say, no, I would not use it as a class 1 wound. Why should I use antibiotic? Type of mesh, which mesh type causes more infection? No consensus. But what is true is that if PTFE becomes infected, it is troublesome. So which mesh will be infected? We don't know. But if the infection is there in PTFE, it is a lingering infection, right? And which mesh type should you prefer in presence of infection? No consensus. That's the bottom line. Recurrences, risk factor for recurrences. You have a large size hernia, more than 5 centimeter width. We talk about the width of the hernia, right? So if you look at the open and laparoscopic, these are mesh repairs, right? We talk about mesh repair. So 11% at 1 year and 28% at 5 years. Laparoscopically, 15% and 29%. So basically, you're looking at same 11, 15, 28, 29. So there's not much difference in the recurrence rate. If you're doing an open mesh, the recurrence is 11%. Laparoscopic mesh is 15%. Similarly, open at 5 years for 28%, laparoscopic 5 years. So recurrence rate is not a thing to be choosing when you're choosing between open and laparoscopic. That we already discussed, right? Tissue repair versus mesh repair. We all know we are doing a mesh repair. It decreases the recurrence rate by almost 50%. We all know that, right? What is the site of recurrence? Most common we said edge, but almost 40% have been in midline, especially through a central fracture in the mesh. The mesh is fractured. And when has it fractured? When you use a low weight or use an ultralight. That was the reason why ultralight were given up. Ventral hernia, you apply ultralight, it breaks. The two edges, you apply it under two edges. When the two edges separate, it takes one part of the mesh with it. This takes one part of the mesh with it. So it is fractured in between. So ultralight and low weight meshes, they have a central fracture. So almost 40% give rise to a midline recurrence. When does it occur? The average time appearance of the recurrence is 26 months. Remember this. Pretty much almost sure across all age groups, right? Previous surgeries, either previous ventral hernia repair or inguinal hernia repair, bound to recur. The more times you operate, the more the recurrence rate. One time operation, second time maybe only 12%. Third time operated, 20%. Fourth time operated, so on and so forth. Why? Because the wall has become weak and weak. Then a surgery like abdominal aortic aneurysm. These are surgeries where you have an increased amount of recurrence. If the patient has got an altered collagen ratio of 1:3, more of 3, less than 1. Less 1, more 3. That means less mature, more immature. Wall is weak. Other technical faults, incomplete radiolalysis. So these are basically the causes of the cause for recurrence. So these are mesh related causes. How does the mesh? These are the figures that I put forward. Now what are the mesh related causes? The mesh size and configuration. Too small mesh, inadequate overlap. Less than 5 centimeters, 60% recurrence because of that. Migration, you had put a mesh at point A, it went to point B. Point A is left open, so it migrated. Configuration, very large pores, more than 4 millimeter. Did not give you tight enough collagen or strong enough collagen. The mesh has rolled. The tackles that you applied at the margin have separated, so the mesh rolls. Ultralight or lightweight mesh, I just not told you. Very bad for recurrences. Mesh fixation has not been good. And that is why I said always use a combination of TFS plus tags. Always do that. Or you have applied a tag and you want to remove the tag, you create a hole in the mesh, a slit or a keyhole. Or the tag was applied too tightly. You may have noticed this. One of the options when you are using it, that you apply a tag very tightly, it cuts through the mesh. It cuts through the mesh. That becomes a slit or a keyhole, a site for a future hernia generation. Or you have never stapled the mesh, like for example, inguinal hernia, TEP repair. We don't always staple the mesh. We don't always stack it. Just leave it. That may be reason. The mesh slipped, right? Or mesh displacement. Why? Apart from a technical fault, there was a hematoma collection. That hematoma kept on separating the mesh from the wall and then subsequently separated. Or seroma. Shrinkage or contraction, about 40%. Curling, we already talked about that, basically after encapsulation. Or there is mesh infection, one of the most important causes for recurrence. Infection in the mesh. Wrong plane of placement. Why? That is where the Pascal's law come in. And based on the Pascal's law, we know that preferably the mesh should be positioned in a ventral hernia where as an IPOM, a preperitoneal, or a retrorectus. 3 places only. Inside the peritoneum, in between the peritoneum and the wall, that's preperitoneal, and in between the posterior rectus sheath and the rectus muscle. Only 3 places where the Pascal law works for you, and that is the position where the mesh should be pushed. Remember, put there IPOM, preperitoneal, or retrorectus. 3 places. Number 2, minimum overlap of 4 to 5 centimeters. Why? Because when the abdominal wall is being pushed by the intra-abdominal pressure, is going to push against the mesh. And suppose if you have not closed the opening, you just put a mesh there, what's going to happen? Where would the maximum pressure exerted? Over the mesh which is lying in the opening or underlying the opening. So each time the pressure works, the mesh would come separated from the moorings. Whether it is a tag or it is a transfacial suture. Remember that even transfacial sutures are not 100% guaranteed. So each time the interperitoneal pressure works or exerts itself against the mesh, and if the outside the opening still exists, you've not done the anatomy correction, then this mesh is going to bulge out. So that is the recurrence, right? So in very large defects, the Pascal's law will not stabilize the mesh. Instead, the Pascal law tell you that in very large defects, if you don't restore the anatomy, the mesh will balloon out, right? And of course, suppose if you put the mesh in between the skin and the wall, what's going to happen? Every time with every rise in IAP or cupping event or vomiting, this mesh will be pushed against what? Against the skin, and it will extrude. So remember, that is why, remember when you talk about ventral hernia repairs, the the restoration of anatomy is now becoming the norm. That means close the defect. Restoration anatomy is what? Close the defect and only then put in a mesh. Especially when the defect is large. When the defect is large, you should always do that, right? Now, other things, you have stretched the mesh too tight, right? You know there's too many wrinkles, and I've been told there should be no wrinkles. I was studying it. I was listening to a lecture, and I read in a book that the mesh should be non-wrinkle. But non-wrinkle doesn't mean stretching it. It should be flat. There's a difference between flat and stretching. Just apply it flat. Don't stretch it. What is going to happen with stretching? Stretching, number one, the moorings are going to cut against the mesh. Number one. Number two, when the mesh starts contracting, what is going to happen? Everything will cut through. It will cut through. So contraction, all the moorings go away. So remember, the problem with too tight stretching is that they are going to cut, right? So these basically the other thing that you have to remember is that why do the hernia starts at the border of the mesh. Now let's say you use a heavy mesh, right? That is now what? A non-stretchable part. Okay? Non-stretchable part and stretchable part. This stretchable part keeps on stretching. This is not stretching. So we have got stretching out here. Now where is the force working? Force is working here. Working here. Every time this stretches, there is a force working here. Gradually what's going to happen? This will become weak. So the shearing force is working between a moving part and a non-moving part. This is the mesh and this is your wall. This keeps on expanding. You cuff, expands. You vomit, expands. And this, what happens to this? It doesn't. So shearing force. So these shearing forces which are there at the interface of the mesh and the abdominal wall only when the mesh is a total replaced by collagen or it has become a total mesh plug, right? So whole thing is a collagen mass rather than a collagen mesh. It is now a collagen mass. So when you have a heavy weight, it sticks and shearing forces are there, and that is why it becomes loose, and from there the hernia starts. And that is why a large pore mid-weight mesh. Another feature in favor of that, right? Another feature in favor of that. So if the recurrent, so what happens? You have opened the abdomen, you've done a laparoscopy again, and what do you find? You find a recurrent defect is through the mesh. What do? You primary repair with the permanent suture bites through the previous mesh. Like I told you, medium fracture, take bites through the meshes on either side. All that may be required. Above or lateral to the mesh, then you have to be another mesh which should be underlay or sublay technique, either laparoscopy or openly by the side of the mesh. So the mesh is here, there's no recurrence out here, the abdominal wall, the occurrence has occurred here. So put in another mesh, right? Now, when the mesh fracture is larger than 2 to 3 centimeters, then the thing is, the whole question is, should you remove the old mesh or not? The bottom line is, if it is not infected, don't try to remove it, contrary to what may be said. Now, what this recommendation is, that you should prevent layering of mesh in the abdominal wall, should explant the old mesh. That is true only if the old mesh is infected. Agreed. Old mesh infected, explant it. Don't put in new mesh until the explant has been removed and the infection has gone up. But if the fractures occurred or the recurrence of hernia has occurred through a mesh and the mesh is not infected, don't try to remove it. Why? You're creating much more problems in trying to remove an old mesh. Why? Because so much fibrosis, that the moment you try to remove the mesh, you create a lot of problems for yourself and the patient. So much messy, so fraught with complications that you shouldn't do it. So, in non-infected old mesh, don't remove it, put in a new mesh. Infected old mesh, explant and put in a new mesh. Bottom line, agreed? Adhesions, what about adhesions? IPOM adhesion, they always start with what? Fibrin and filmy. We all know that. You operate on abdomen, we all know for the first 3-4 days filmy, and gradually the fibrous tissue now starts invading, and then it becomes a fibrous adhesion. When does it become the fibrous adhesion? Second week. That is why the dictum, do not try to re-operate in a patient, preferably in the second week. If at all, don't do it. If you can, of course. The emergency condition, you have to do it. But prefer not to re-operate in the second week. This is the reason why that these adhesions have now become fibrous adhesions. So second week, most dangerous time for re-operation. right? Now, so this is basically the sequence of events happening. At the same time, what is happening is that the adhesions are being controlled by what? By the mesothelial, some mesothelial cells. By how they control it? They are controlling by their fibrinolytic activity of what? Discrete plasminogen activator. This plasminogen then comes plasmin, which breaks the fibrinogen, the fibrin it breaks the fibrin into fibrin degradation products, FDPs. So basically, fibrinolytic activities occur, right, because of plasminogen activator. Now, these mesothelial cells have appeared second week and they are completed by 4 weeks, right? Now, this time period, by this time, the fibrinolytic activity would be at its maximum. So once this activity appears, whatever adhesions appeared will be there, but subsequently no more adhesions. That's why it is said that whatever adhesions appear are always, the genesis always in the early phase of the event, whatever index operation you have done, right? Early, the adhesion is always there. So, but is it as easy as that? No. The fibrinolytic activity is being inhibited. That can also be inhibited by what? By infection. It is what? It's decreasing the number of mesothelial cells. There is infection, the mesothelial cells do not grow. So, this fibrinolytic activity suffers. What else? Tight suturing, a prosthesis, they're all retardants. Now, this tight suturing leads to what? Peritoneal ischemia. The more tight the sutures, peritoneal ischemia. What does peritoneal ischemia do? It inhibits fibrinolysis. It stimulates adhesion formation and reduces number of mesothelial cells. All three in favor of increased adhesion activity. Now you know why. Now we advise that when closing the abdomen, you should not close the peritoneum. Leave it. Don't try to close the peritoneum. This is the reason. You always increase the adhesions, right? So don't forget, it's got offshoot of this. This is the reason why you should not try to close the peritoneum. Okay. So as I said earlier, always start early soon after mesh implantation. And the incidence with PTFE, polypropylene, and polyester, 36 to 100%. Remember, it's not adhesive intestinal obstruction. Remember that. Time and again, I'm trying to drive this home into you. No, next time when somebody asks you, don't say 100% of the time a patient with PP mesh will have adhesive intestinal obstruction. I'm not saying that. I'm saying adhesions are there. Right? Now, so basically with PTFE slightly favorable. Why they say PTFE has filmy nature of adhesions, and that is why it's easily dissectable, and that is why it is advised that among the three, if at all you want minimum adhesions, you should select a polytetrafluoroethylene, right? PP and PET, they are more dense. And we all know the treatment of adhesive intestinal obstruction may be highly problematic, may be easy, but always do a sharp dissection, if possible, from the wall, include the parietal peritoneum, dissect the parietal peritoneum rather than trying to dissect in between the parietal peritoneum and the bowel. And if possible, do not use an energy source. Erosion and fistulization, which I refer to when talking about ventral hernias, and this is one topic which is a burning topic for the simple reason that which mesh should you use? Let's proceed now in direction. Seen on an average 2 years after index operation. What have we done? Let's say you repaired a ventral hernia. 2 years later, if at all it has to be, it will be there. But the rate can vary up to 7%. When in the elective ventral hernia operation, you had an enterotomy or there was an unplanned bowel resection that you had to do, right? So you're operating for a ventral hernia. Often you must have seen that. You open a hernia and for some reason you have to either you negate the bowel, that entropy happened, or for some other reason you saw another pathology, you said I have to remove this, a stricture there, so I do a bowel resection. So in that case, when any kind of enterotomy has occurred along with a ventral hernia operation, or you have done a bowel resection, in that scenario, the rate of fistulization increases to almost 7%. Right? Now, these often present as chronic mesh infection. That is one of the best methods. You have a sinus or you have very small leaking content which resembles fecal mass. And this is basically what? This is an infection, sinus appeared first time, some pus, and then over 2-3 days, what do you find? Now you find some kind of fecal discharge or bilious discharge for that matter. That means it has got an underlying fistulization. And what is the mechanism? Number one, excessive scarring. Bowel sticks to the scar. Now what happens? Each time the abdominal wall moves, the scar and the bowel move against each other. They move against each other. So there's abrasive surface where the bowel has got a continuous peristaltic activity, and this abrasive surface, the bowel keeps on moving to a peristaltic activity. So there's a shearing force between the peristaltic bowel and the mesh. And that leads to what? The mesh erodes into the bowel, causing a fecal fistula. The second method by which the fecal fistula forms or anticose fistula forms is a mesh migration. It loses its moorings and it is now lying inside the abdominal cavity, goes and fixes to a particular part of the bowel, or part of the mesh is dislocated from the abdominal wall, part of it has dislocated, it goes and attaches to the bowel. So again, in either case, mesh migration leads to fistulization. Now, it was always believed and still believed whenever you go to any conference or any workshop, one thing they will always drive home is do not put a PP icon. Don't. Why? May I ask you why? Are there any evidences that it produces more fecal fistulas? No. See this latest. Hernia 2017. Hernia 2017. Latest paper now. No ECF even with uncoated polypropylene mesh as icon. And let me tell you that if fecal fistulation has to occur, it can occur even with a PT mesh, and with a PTFE mesh. Right? Long-term data does not support it, despite the fact that recommendations now in favor of what is being recommended. The recommendation is what is being recommended. The recommendation by the sages, the recommendation by the IEHS says that you should put in a mesh which has been recommended or agreed upon by everybody. By who? By the industry. It is more or less industry driven. Let me tell you, I started doing hernia repair ICOM with polypropylene 95. It's now 25 years, not a single case of fistulization. I'm not the only one. You go to the net and you can see a host of papers who say that polypropylene put as an IPOM does not give increased incidence of fecal fistulation, increased level of fistulization. So when you compare all the meshes, why only single out polypropylene is the most cheap and does not give you too many complications. So why not use it? Anyway, so that is basically a debate which I wanted to introduce you into. You can always go and look it up in the net. This is a debate which is ever raging, and in workshops, nobody with a support of IPOM PP would be allowed to speak there, and they'll immediately silence you. You're talking rubbish, and you only want to put in a mesh, which is much more costly, costing about 30,000, 40,000, 80,000, or lakhs. Why? Because they're very happy putting it. Maybe they're getting commission from it. I don't know. Anyway, so erosion fistulization management, how do you do it? Always start conservative measures and control the contamination. Point number one, don't immediately go ahead and start operating on the patient. So control the contamination. Why? Because immediate mesh explantation, as soon as the infection is burst out or the fistula is worked out, is going to give rise to high risk of bowel injury. Don't try to enter that abdomen immediately. Why? You're going to damage much more than what you're going to remedy. Right? And how do you control the contamination or conservative measures? Number one, open the tract fully to control the sepsis. Drain out all the pus, whatever there is inside. Do a CT scan. You see the pus, drain it out. So the first thing you have to do a CT scan. Nutritional support with TPN. Somatostatin. You all know that somatostatin basically decreases all kind of secretion. So you want to decrease the amount of secretion. Downstream decompression, very, very important thing. You have a fecal fistula, and in the distal part, it is blocked. Is that fistula going to heal? No. So downstream decompression must. That means the downstream area should be clear and appropriate wound care. They can all lead to spontaneous closure in many cases. You don't do anything, just do this, spontaneous closure. And in most of these cases, the mesh can be salvaged. You don't want to do anything with the mesh. But if the fistula fails to close, and what is the time? You immediately ask, up to what time do I wait? 6 months. 6 months. If other things are not problematic, like for example, it's a very high output fistula, then of course you may have to go in early. But if other things, it's a small output fistula and the patient not too much trouble, he has some kind of a downstream opening, he has some flatus passage or phase passage. In those cases where the opportunities tell you that you can wait at least for 6 months to allow spontaneous closure and maturing of the adhesion. Only then go ahead and reoperate and do a mesh explantation. Not before that. And what do you do explantation? Either partial or total. What should be preferred? A complete explantation. Yes, partial removal of the mesh creates more problems. Why? Partial mesh Excision leads to what? Higher rate of surgical site infection. SSO, surgical site occurrence. This is a new term. SSOPI, surgical site occurrence requiring procedural interventions. Now, why do they come up with these terms? Just a few words about this. Now, SSI basically is surgical site infection. Right, agreed. Now, what do you call a seroma at the surgical site? What do you call a hematoma at the surgical site? You call it SSI? No, strictly no. Strictly, I would not like to call a seroma or a hematoma as SSI. Is the infection or is not infection? So basically, what is happening? This is basically an occurrence. It's an occurrence. So a seroma or a hematoma in the surgical site would be classified as an SSO and not SSI. Right? Now, the third term, each one of them may not require any kind of intervention. It is a SSI resolved by itself. Or seroma resoluted, hematoma disappeared. Did I require any surgical intervention? No. But there may be a case where it may require surgical intervention. So all those surgical site occurrences which require some kind of procedural intervention are known as SSOPI, and this classification has now become accepted by the plastic surgeons and by the surgeons who are only dealing with, the gastrosurgeons only dealing with ventral hernia. These are accepted terms now. So I think you should know what these terms mean. SSI, SSO, and SSOPI. Right? So if possible, do a complete explantation. If not, remove all that you can. But partial, remember, is always going to create problems with this. Right? Okay. Now, ventral pain and inguinal 33% of patients, it is either neuralgic or neuropathic. Neuralgic, why? Nerve entrapment, perineal fibrosis, and then of course you can have an area of hyperesthesia. Neuropathic, then anesthesia, later hyperesthesia, and contact anesthesia. I'm not going to be details of that, but just remember, in all these patients, what's happening is either your TAC or a transfacial suture is damaging one of the nerve endings, right? So either it has severed the nerve ending, or fibrosis occurred across the nerve ending, or there has been a temporary neuralgic event for the nerve ending. So in any case, your tacker that you put in, the tip of the tacker has now got an impingement on the nerve. So it can occur with the transfacial, it can occur with the intracorporeal, it can occur with TACs, right? It can also occur with absorbent TAC. Absorbent TAC, one thing good is that whatever the pain was there would disappear after the TAC has disappeared. It has absorbed itself. Transfacial sutures, because it's gripping, and that is why what is advised is that the transfacial sutures should always be applied with absorbable sutures. And the best, of course, is polygalactic or polyglycolic. Do not use proline. Initially, we used to use proline, don't use. That means the grip which is there would be there only for the grip on the wall would be there only for the time until the mesh disappears, until the suture disappears. 60 days, 90 days. So, in these cases, basically, when you have inguinal or a ventral pain of temporary nature, you can do that. But if you have a permanent nature pain, where suppose fibrosis occurred and entrapping of the nerve, then you may have to do some kind of a neurectomy or some kind of a permanent injection, either chemical neurectomy or surgical neurectomy. The other infection, the other complication, seroma in 10 to 15% cases, but in literature, even up to 100% is mentioned. Differential diagnosis is very important, and that is the recurrence of hernia. The patient immediately comes to you, I have this bulge, what have we done? I have this hernia again. It's not a bulge. Pre-operative explanation of the patient should be given that you may have this kind of a collection which will mimic a hernia for you. Don't be worried. Because 90% of the time, it will disappear in 6 weeks. If it doesn't, then that creates a problem. We like to go into a repeated aspiration, which is fraught with the danger of infection. You have to be very, very careful. Or you may have to do an excision of a chronic seroma, where the seroma has been there for a couple of months and a fibrous ball has been formed around it. Then you have to go in for excision of seroma. A shrinkage of the mesh, 20% shrinkage, when laid in place, the process should never be taught, and that is upper level of shrinkage that you want. You don't want anything shrinking more than that. Then rigidity and buckling that is often felt at the patient, that is basically their prefix plug repairs, or you have a heavyweight mesh inserted. So with loss of diabetes, that creates a problem. The others, unrecognized bowel injury, you can have bladder fistulization, or you can have extrusion of the mesh through the defect, the subcutaneous plate that I talked to you about. where you don't restore the anatomy, the defect is there, underlying mesh is there, and every time the mesh starts pushing against the defect and comes out. So extrudes to the defect. And overlying pressure necrosis skin and extrude to the exterior, that may also occur if the overlying skin is very, very thin, right? So which mesh? The bottom line, which mesh? Polypropylene, PTFE, polyester, type of hernia, cost, we don't know. You don't know. I said earlier, no one single answer to all your problems. Clinical and experimental data hint at what? PTFE is more durable, most inert, least but adequate inflammatory response with minimal additions. But for intraperitoneal placement, dual meshes are better any day. Which dual mesh? That's for you to decide which one you want. And finally, what are the updates and future researches? One, clean contaminated ventral hernias. It's a very, very important subject. And that is, we always said, put in a biological mesh and do a later on replacement. Right? Macroporous modified moderate weight PP meshes are acceptable and give better results than biomeshes. I just not told you when we talk about biomeshes. So remember, clean contaminated or contaminated, CDC2, CDC3 type of SSIs, prefer what? Polypropylene, macroporous, moderate weight, not biomeshes. Debatable results in ventral hernia, but can be used for interval bridging in traumatic abdomen, but at the cost of huge cost. Developing hybrid meshes, I just not told you, these are basically the XLM matrix, the Xenapro hybrid. We're talking about hybrid. They're more of experimental, still under clinical trials. Self-expanding systems are there, where as soon as put inside, the wires are there, they open it up. Then you can have cell-coated hybrid meshes. You have a bias scaffold seeded with human adipose derived stem cell. So you got the animal scaffold, and over that you put in the human adipose derived stem cells. This is another type of hybrid meshes. Synthetic meshes now coming with anti-inflammatory properties. They've got a coating of hydrogel that decreases the foreign body reaction. You got antibacterial meshes where the antibiotic has been seeded to the mesh, and they use every antibiotic under the sun. Vancomycin and plenty of others is being manufactured and marketed by Gore. Now these are all there. These meshes are all there. Don't think that it's only experimental. Then meshes with metal ions are there, silver, gold, palladium. They've got antibacterial property and less additions. Mesh with enzymes are there. Mesh with nitric oxide is there. Nitric oxide incidentally retards the biofilm formation of a bacteria.